Hello, my name is Stamatia Destunis. I'm a radiologist at the Elizabeth Wendy Breast Care in Rochester, New York. What we're going to do today is talk about screening breast ultrasound and specifically automated breast ultrasound. So we're going to talk about today the clinical implementation of ultrasound in breast imaging. Breast ultrasound is a very useful tool to evaluate lumps and pain in the breast tissue. We use it as a first-line imaging tool in young women and pregnant women in their first trimester specifically, where we may not want to use any X-ray imaging. Advantage of ultrasound in the tissue is that we can observe the tissue without radiation, and it can be imaged much faster than with X-rays. There have been no substantiated ill effects documented through the study of the use of ultrasound. Diagnostic breast ultrasound specifically is an ultrasound exam ordered by a physician to evaluate a symptom of concern or mammographic abnormality. It's also used for evaluation of lumps and pain in the breast tissue. And as I said on the prior slide, a first imaging tool for young women and pregnant women. Screening breast ultrasound, however, by definition, an exam is referred to as screening when its purpose is to learn if a breast thought to be healthy has any signs of cancer. The types of ultrasound that we use in clinical practice are two-dimensional ultrasound, three-dimensional ultrasound. That is actually two-dimensional ultrasound with specialized software applied to form a 3D image. This allows improved visualization of an organ. We also have Doppler ultrasound, which measures the change in frequency of echoes and calculates how fast an object is moving. This is used predominantly for blood flow measuring. Traditionally, and for us in breast imaging specifically, we use high-frequency ultrasound. That's anywhere from 7 to 12 megahertz or 7.5 to 13. And what this is, it measures the sound waves and their echoes and produces a two-dimensional image. The ultrasound unit will calculate the distance from the probe to the tissue or organ using the speed of sound in the tissue, which is 5,005 feet per second, and then the time for each echo's return. These are the types of ultrasound probes that we use in our facility. Linear array ultrasound, it's an ultrasound beam that's produced by a narrow element, and this diverges rapidly after the sound wave travels only a few millimeters. The smaller the face of the transducer, the more divergent your beam, and that gets combined with adjacent elements simultaneously with the delayed pulse. This results in a very focused beam from the divergent wavelets. Compound imaging is the acquisition of multiple image frames from different viewing angles. The overlapping frames are then combined to form a real-time image on your ultrasound display. The image quality greatly is improved with increasing frame number. If you're interested in reading more about these different types of imaging, you can go ahead and read on by Quack Variable Breast Conditions in comparison of conventional and real-time compound ultrasonography in the Journal of Ultrasound in Medicine. Tissue harmonic imaging, however, is the generation of harmonic frequencies as an ultrasound wave propagates through the tissue and reduces artifacts and also improves image clarity. The benefit of this is you utilize lower frequency sound waves to improve your penetration of the tissue while receiving and processing only the higher frequency echoes produced by your body's inherent harmonic characteristics. The tissue beam transmits at one frequency and receives at twice that frequency. On this slide, we're looking at patient positioning. When we do ultrasound, you are able to maneuver the patient in order to bring the lesion or whatever area of interest you want closest to the skin surface and closest to your ultrasound beam. You see that the patient has her arms over her head, also turned to the side. We also document using the clock face and also depth, as you see on the sagittal view. We have to use every modality available to us in order to be able to document where an abnormality is seen in the breast. When you scan with ultrasound, you have to scan at least two views, whether you use the radial or anti-radial approach or the transverse or longitudinal approach. You have to document how you're scanning and take appropriate images. The American College of Radiology has the ACR BI-RADS lexicon, which is actually very helpful for us for ultrasound. It explains to us how we should have our dictation so we are consistent, whether the patient returns to us for a follow-up visit or may move out of town or out of the country and need their reports and their imaging. We have to discuss the texture of the tissue. We have to discuss the masses, if we do see any, calcifications. There are special cases which we'll discuss a little bit more, and also vascularity. The texture, we have some images here. These are courtesy of Dr. Mendelsohn. You see the homogeneous fat, which is very easy to look at. It's all the same type of gray-white, and we can see cystic spaces within this area. Over here we have homogeneous fibroglandular tissue. These images are courtesy of Dr. Berg. And here we have heterogeneous tissue, where you see much more of the darker and also the whiter tissue. So fibroglandular tissue can be homogeneous or heterogeneous. Fatty tissue typically will be very homogeneous. Now for the masses, when we describe them, we can describe the shape, which may be oval, round, or irregular, the orientation, whether it's parallel or perpendicular to the chest wall, the margins of the mass, the lesion boundary, the echo pattern, posterior acoustic features, and the surrounding breast tissue. Starting with the orientation, when you have a benign appearing mass, such as this mass, this is a fibroadenoma, this is parallel to the skin and it's wider than tall. This has ultrasound findings that correlate with a benign entity. When you have a carcinoma, such as in this case, this is not parallel, this is taller than wide, and this has decreased through transmission, and these are findings are suspicious and indeterminate on ultrasound. This turned out to be a cancerous mass. When we look at the margin of a mass, we want to describe whether it's circumscribed or not, whether the margin is indistinct or angular, microlobulated or spiculated. We want to discuss the transition zone and the lesion boundary. Is there an abrupt interface or an echogenic halo? What is the echo pattern? Is it anechoic, such as that we may see in cysts, hypoechoic in masses, complex, cystic and solid component, hyperechoic or isoechoic? This is an old case, but it's a very good one. This has the posterior acoustic features, the posterior acoustic enhancement that we found even many years ago with cystic structures. When you look at posterior acoustic features, are there any? Is there enhancement, such as in this case? Is there shadowing, such as in this case, or maybe something combined in between? This is a case of fibrosis on the right, and on the left, a typical cyst. The surrounding tissue, we look at the ducts, the Cooper's ligaments. We look at, is there any fluid, such as edema? Is there architectural distortion of the tissue? Is there skin thickening or skin retraction? When you're imaging, you want to evaluate, is this what you're looking at benign entity? Is it cystic or solid? For cysts, we look at posterior acoustical enhancements, such as the prior old case, but good case that I showed you of a cyst. Is it well circumscribed? Is it anechoic? Are there echoes within it? I'm going to show you some examples here. This is a 46-year-old that presents with a right lump and pain in the 12 o'clock region. This is her mammogram. This is the right medial lateral oblique view. This is the left, and one of the CC views here. She has dense breast tissue, as you saw on the mammogram. And now we move to her ultrasound. This patient has multiple bilateral cysts on ultrasound. We talked about right 12 o'clock lump and pain. In the right breast upper outer quadrant, she has anechoic structure with increased through transmission. This is a cyst. It's well circumscribed. Several cysts here in the left breast. And these are a benign finding. And very easy to distinguish that on a breast ultrasound of today. This is an ultrasound, a set of images from an outside facility. The patient came to us for a second opinion. She had an abnormality or a questionable abnormality in outside mammogram, and then had an ultrasound that was indeterminate. You see that this is a poor ultrasound set of images. It's difficult to tell what is fibroglandular tissue. Is this a real lesion, or basically a fake out because of the way that this patient's breast was scanned. We repeated the ultrasound in our facility, and within the right breast, you see there is a hypoechoic irregular mass. It's taller than wide. It is not well circumscribed. It has irregular borders. It has decreased through transmission. And this is a sagittal image of it, and here we have a transverse image of it. This hypoechoic mass is suspicious and required a biopsy, and on this image here you see that we're performing a needle biopsy. And here is our needle biopsy going through the lesion. This was an invasive ductal carcinoma. We were able to do this biopsy under ultrasound since we were able to find this mass on ultrasound. This next case is a 55-year-old that comes in with a palpable lump in the right breast. You see she also has dense breast tissue. Here's the right craniocaudal view, left, right MLO view, left MLO view. We cannot distinguish any abnormality on this mammogram, but her tissue is dense, which may limit our sensitivity mammographically. So here we have the patient's area of palpable thickening on ultrasound. She has a simple cyst. It's anechoic. It has increased through transmission, well circumscribed. So this is what she felt. However, while we were in the right breast scanning the whole breast, we also found an incidental cancer. This is an irregular mass with irregular borders. It's solid, and this turned out to be carcinoma. Complicated cysts may be hypoechoic. They may have multiple low-level echoes because there's a lot of pernicious material and debris, blood within them. They frequently may have posterior acoustical enhancement. These may need to be aspirated to know for sure what's going on. This is a young patient with a strong family history of breast cancer and presents with a left lump to our facility. And here you see the typical heterogeneous dense glandular pattern of her mammogram. And her lump in the left breast turns out to be this complicated cyst. It has a cystic component, a solid component to it. It has mildly increased through transmission. This on needle biopsy was just an inspissated cyst and a benign finding. Hung published some important data in AJR in 2005 about solid masses, and he used the BI-RADS for ultrasound and positive and negative predictive values of sonographic features. He had 403 solid masses by ultrasound that had undergone biopsy and were analyzed by the BI-RADS lexicon. What he found was top predictors of malignancy, which he has outlined here in this table. By using the BI-RADS lexicon, if the lesion is round, he only had a few of those, but 100% malignant. If it's spiculated, 19 out of 22 or 86% of them are malignant. If there's an echogenic halo, 70% malignancy rate. If it was not parallel to the chest wall, 69%. Irregular borders, 62%. He also looked at top predictors of benign findings using the BI-RADS lexicon. If it was hyperechoic, meaning more echoic than the rest of the breast tissue, all of the lesions he had were 100% benign. If it was a complex or complicated cyst, 18 out of 20, 90% were benign. If it was well circumscribed, 90% benign. If it was oval, 84% benign. If there was no posterior enhancement, 79% were benign. So for the benign nodules, there's several of these. We have lymph nodes on this list, phylloides, lactating adenoma, galactocele, fat necrosis, papilloma, fibroadenomas. We're going to talk about each one of these. This is a young patient. She's 32. And she's currently breastfeeding. She presents with a right breast lump. So we can see here, this is the medial lateral oblique, very dense breast tissue, the same thing on the craniocaudal view. You cannot distinguish the lump in her breast. But when we do ultrasound, we do see this hypoechoic region, which is smooth. So there's a mass here, which you can see within the right medial breast. It's ovoid shaped. And this on small needle biopsy was a lactating adenoma, which is a benign finding. Another young patient, breastfeeding also, with a mass, presenting for evaluation to our center. And so we see here that there is a nodular region that you can see on the craniocaudal view, and here it is on the medial lateral oblique view. This on ultrasound turned out to be a partially cystic mass. You do see the cystic component, which is anechoic here, but also there's some solid component within it. The borders are fuzzy, they're not smoothly outlined. You see a solid component here to this. And we aspirated this, and this was an infected galactocele, basically an infected pocket of milk. This is a patient that comes in with spontaneous discharge, and when we do have patients that come in like that, we evaluate them. We frequently have to do what's called a ductogram, which is find the duct that's leaking from the nipple and cannulate it and inject non-ionic contrast to outline the ductal structures and see if there's a mass or what's causing the discharge. In this patient, you see a lobulated filling defect here on this ductographic image, and it also persists on the orthogonal view. So this patient had a mass that was causing her discharge, so we were able to go to ultrasound next and find the dilated duct and the mass within the duct, which you can see here. And here's another look at the mass within this dilated duct. So the mass is causing obstruction here, and it's creating fluid, and it's also causing the leakage of the fluid at the nipple. This on needle biopsy was a papilloma, which is a benign growth that can occur in the duct and can cause discharge. So when we talk about imaging and evaluation of malignant lesions, we think of the several important articles, specifically the article by Tom Stavros that was a landmark article. He characterized malignant and benign and indeterminate findings. This was published in Radiology in 1995. The malignant findings are speculation, angular margins, marked hypoechogenicity, shadowing, calcification, duct extension, branch pattern microlobulation. Also, he had several benign findings. He put everything in the benign category if they didn't have any malignant findings. If they were intensely hyperechoic, if they had ellipsoid shape or gentle bi or trilobulations, if they were thin or had an echogenic pseudocapsule. Indeterminate findings. Well, there's a lot of things that could be in the indeterminate category. If they were isoechoic, if they were mildly hypoechoic, if they had normal sound transmission, if they had enhanced transmission, if there were heterogeneous texture, as I showed you earlier on some of the earlier ultrasound images, or homogeneous texture. So many things that don't quite fit in the malignant or the benign category are in the indeterminate category, but some things definitely can be in more than one. This is a case of a 55-year-old that had a history of cysts, presented with a palpable lump. And you see this dense glandular tissue. I showed you this earlier. This is a patient that it's important to have her in more than one category, and I'm going to show you again why. So this is her right breast. The mammogram shows dense breast tissue. We really do not see an abnormality here, neither on the craniocaudal or the medial lateral oblique view. Bilateral ultrasound was performed. We always do bilateral ultrasound when we have a patient coming in with a concern. Her lump was at 9 o'clock, but we also located the second lesion at 6 o'clock. So as I showed you earlier, the 9 o'clock mass was a cyst, but the 6 o'clock was an incidental invasive ductal cancer. So it's important when you're there and you're doing ultrasound not to stop and have satisfaction of search. You found a cyst in what she's feeling or her area of concern, but you're holding the ultrasound. It'll take just a few more minutes to go ahead and image the rest of the breast, and an incidental cancer was found. Ultrasound advantages are many. The low cost, no radiation, it's fast, it's comfortable to the patient. They're lying supine as opposed to in an uncomfortable position for other testing that we do. And it's real time. You're actually seeing abnormalities, or you're correlating with what you're feeling. You're palpating the area, you're finding a cyst, you're able to do real time, on-time correlation. We use second look ultrasound for our patients after we do MRI and we find an MRI abnormality. It has helped us in many situations. Otherwise, the patient will be subjected to an uncomfortable MRI biopsy. So second look ultrasound has had quite a bit published. There is some of the landmark articles, such as Lantrenta in Radiology in 2003. Her article showed that second look ultrasound failed to identify the abnormality in up to 77% of the cases. So she found an abnormality with MRI in a patient that had a reason to have an MRI, and went back and looked with ultrasound to find that MRI abnormality, and she couldn't find it in 77% of the cases. However, when she was able to find an ultrasound correlate, those patients had a higher incidence of cancer, 43%. But even when she couldn't find an ultrasound correlate, she couldn't give up. You had to keep going because 14% of those patients could have cancer. Indications for breast MRI there are several, but specifically the diagnostic arena is for extent of disease. And what that means is patients that just got diagnosed with breast cancer, and before they go to surgery, you want to really help the surgeon plan out the surgical approach and want to measure the lesion in more than just with the mammogram or ultrasound, and these are extent of disease. You also want to do this preoperatively. It's much easier to go ahead and look for extent of disease prior to any surgical intervention, because surgery causes a lot of changes and that makes it a bit difficult. You also want to do it sometimes in post-lumpectomy patients if the margins are not clean or are close. You want to see if a patient that's on chemotherapy for their breast cancer is responding. You want to look for a recurrence in patient that has a history of breast cancer in the past and a questionable workup. You want to look for a primary cancer in a patient that has an axillary lymph node that's positive for cancer. In patients that have silicone implants, you want to look for ruptures. And sometimes in very difficult workups, such as the mammogram is confusing or not helpful, the ultrasound and breast exam are confusing, a biopsy was indeterminate, MRI may be helpful. And we use it for high-risk screening in patients that have the genetic, they're genetically at risk for breast cancer or have a personal history of breast cancer or atypia. So in the extent of disease patients, this is a 66-year-old. I'm going to show you some examples. She presents for evaluation of a lump she felt for 2 weeks. You can see this area of coarse calcium. This is a benign fibroadenoma, but the patient's lump was not in that area. Her lump on this tangential magnification mammographic view is right here. You can see lines coming out of this area. Here is a metallic marker on the skin telling us that this is what the patient is feeling. This looks suspicious mammographically. On ultrasound, this was also very suspicious. You see this irregular solid mass with angular margins. It's hypoechoic. It has decreased through transmission, and this was carcinoma on ultrasound-guided needle biopsy. It was an invasive ductal cancer. So as per our protocol for our center, the patient went on to have breast MRI to really kind of plan out the surgical approach for the surgeon. And prior to her surgery, what we saw was here is her known cancer on the sagittal view, and here it is on the craniocaudal view. However, this patient has other satellite lesions such as this one, and another enhancing lesion here, and another enhancing lesion here in the superiorly, which is in the upper inner quadrant. So she had kind of a background, a stipple pattern also bilaterally, which speaks of fibrocystic disease, but this patient had more than one lesion, so the MRI was very helpful. This patient's not a good candidate for a lumpectomy procedure. However, to prove that, we went ahead and did second look ultrasound, and on second look ultrasound, now that we know in the upper inner quadrant of her left breast there is a second lesion or multiple other lesions, we found this irregular mass and we biopsied it under ultrasound, and this was also invasive ductal carcinoma. This really made it simple to know what to do for this patient and what the surgeon had to do. This patient needed a mastectomy. This is a 41-year-old. She comes in for a screening mammogram. She has a history of prior lumpectomy a few years ago in the right breast, and she scheduled herself as a high-risk screening mammogram and MRI. She has a kind of typical heterogeneously dense glandular pattern that we see in our young patients. Here's a magnification view, however, near the region of her scar, and we see this lesion. There's a mass right here, which is medial on the craniocaudal view. The patient was also scheduled for MRI, so she went on after her mammogram to have her MRI, and we see this enhancing mass medially, very suspicious. So now we go ahead and bring the patient and do targeted ultrasound of that inner part of her right breast, and this lesion that's quite subtle, hypoechoic, angular margins, decreased through transmission is here, and this required a biopsy, and you can see our needle biopsy going right through it. and this turned out to be invasive ductal carcinoma. So here's our needle up here and going through the lesion. This is a small lesion, so the ultrasound was very helpful as a second look ultrasound after the MRI showed us that region. Also, we could also see it on the mammogram. Now, automated breast ultrasound systematically scans the breast, capturing up to 350 ultrasound images. These are images that can be manipulated to produce a 3D reconstruction of the breast. It combines the ultrasound frames together and eliminates random variation and noise. It allows for visualization throughout the entire breast. So automated breast ultrasound is different than handheld, and we'll talk a little bit more about it here. The technical components of this are, and here you can see what the ultrasound probe looks like, how the image is obtained. It obtains a transverse image, which we're familiar with our handheld. This is a cyst here. It also obtains a sagittal image, which is right here, which we're also familiar with, but it obtains a coronal image, which is something new. And you can see that this patient is very cystic because you kind of get a good look at the entire breast with this coronal image. This is a coronal reconstruction. You see nodules, which are cysts in this patient. And we'll talk a little bit more about the coronal image. The technical components are, we obtain a lateral view, an AP or frontal view, and also a medial view. Why do we have to do actually 3 views per breast? Sometimes in small breasted patients, you may not need the medial view, but in most patients, to make sure that you don't miss any lateral tissue or axillary tail tissue or the far medial tissue, you probably do need the 3 views per patient, per breast. So the data acquisition, it's connected to our PACS and our wrists, allowing us to work list our patient. We cannot view the images on our PACS currently as of yet. So we have to read, although it's connected to the PACS, we have to do primary read on the proprietary workstation. Prior to the scan, a membrane screen is attached to the end of the scanning probe. Here's our scanning probe right here. And here you see one of our technologists placing the probe on the patient to start the image acquisition. The patient is lying supine very comfortably. The stabilizing membrane is applied to the scanning probe, and then you use coupling lotion, which is basically, some ultrasound cream, and that's applied to the breast. A preview scan is automatically performed by the probe, by the station, to determine the patient's breast tissue. This evaluation is used to determine the ideal ultrasound imaging parameters. This is all automatic, so you don't actually have to do anything. And then you start the actual image acquisition of that breast. Here are what the ultrasound unit looks like. The patient's lying here. The probe will come down and the technologist will hold it on top of the patient's breast. Here is the unit. You can actually see your images right there. You're able to do 3D simulated real-time interaction. Patient convenience here for sure because they're resting. And it also does give you some scheduling flexibility. You can schedule these patients for the automated breast ultrasound. Your technologist can do it. The images are stored and you can review them later. So the radiologist can, be doing other things, whether they're biopsies or MRIs or reading, screening mammograms. So the advantages of using the automated breast ultrasound, you theoretically, because you're doing a lateral, a medial, and also an AP view, you're demonstrating the entire breast anatomy. You're also doing proper orientation and documentation of lesions, and you have better reproducibility. It may be good for follow-up studies here where you may detect an abnormality and you want to follow, such as a fibroadenoma, you want to follow it over time to make sure it's remaining stable in size. You're also getting volumetric data, which potentially there's a lot of information there when you're thinking about computer-aided detection of breast lesions down the line. And also, it's easy for our technologists to use, and you don't need long periods of training. It's time efficient for the radiologist. Now, how do you implement automated breast ultrasound in your workflow? Well, you may want to use it for your high-risk patients. These are patients that had prior history of breast cancer and their lesion was only seen on ultrasound. The mammogram did not reveal their cancer to begin with. In patients that have dense breasts, in patients that have had prior atypia, precancerous lesions. You may want to Use it for your diagnostic patients where the 3D reconstruction ultrasound images of the breast may assist you in identifying and localizing lesions that could be missed by conventional breast imaging technology. The history of automated breast ultrasound in our facility at the Elizabeth Wendy Breast Care. It started several years ago. We presented a hot topic at the Radiological Society of North America in 2005. These are patients that went on to biopsy, and we did handheld ultrasound, the standard ultrasound, also automated breast ultrasound. We also followed up with a pilot study in 2006, which was conducted under IRB approval. The hot topic had 41 lesions in 40 patients, and the study cohort was predominantly heterogeneously dense or dense breasts, and that's the category where you really do need the ultrasound because those are the type of breast density that you may miss lesions on the mammogram. 93% of them were that type of breast tissue. There was a 91% concordance between handheld and automated breast ultrasound. 2 cases were downgraded from BI-RADS category 3 to 2. 1 case was upgraded from a BI-RADS 3 to 4. None of these 3 cases that were upgraded or downgraded were cancerous. This is an example. This is a 49-year-old presenting with a history of bilateral cysts. She has heterogeneously dense breasts. She has a nodule within the inner part of her left breast on the craniocaudal view. The handheld ultrasound revealed a cyst. This patient also had automated breast ultrasound, and here's a cyst in the AP projection seen very nicely in the transverse and sagittal image. Here you see it on the coronal image also very nicely. So you're able to distinguish this cyst in all 3 projections. Here is in the medial projection. Remember, we do an AP lateral and a medial projection, and here we can see the cyst nicely when we are scanning the medial part of the breast. And here's the lateral projection, also seeing the cyst nicely in the lateral projection. When we looked at our automated breast ultrasound cancer findings, we had 15 lesions that were highly suspicious for cancer when we looked at the automated breast ultrasound. 13 out of 15 were core biopsy-proven carcinomas. The handheld size was 14 millimeters with a range of 6 to 31. 54% of them were non-palpable, and the automated device illustrated all the cancers on at least one view. This is another patient. This is a 67-year-old. She came to us for a second opinion of a mammographic abnormality. This is a spiculated mass in the right 12 o'clock area. Here's a handheld ultrasound, irregular hypoechoic mass. On core biopsy, this was an invasive ductal carcinoma. Here it is on the automated breast ultrasound, and you see this hypoechoic mass, so you can see it on the coronal, transverse, and sagittal images. Here it is on the medial projection, and also on the lateral projection. So we were able to see it in all 3 projections. So we had good correlation between handheld and automated. The pilot study that we initiated in 2006 was phase 2 of our clinical evaluation with automated breast ultrasound. The results of that, we had 292 screening breast ultrasounds in 147 participants. 98% were dense breasts. We looked at the non-recall patient's time that it took us to do the examination, and also for the recall patients. It took me longer to interpret the exam, obviously, when I was going to recall a patient. That was an average of 17.5 minutes per breast, as opposed to for the non-recall patients, 5 minutes per breast. The interpretation time also increased with the breast size because we had to do additional views to ensure total breast imaging. We did find some new findings. This is a 66-year-old that came in for a screening mammogram. She did have the heterogeneously dense breast tissue. When we did do the automated breast ultrasound, we identified this hypoechoic area that you can see on the coronal view. Here it is on the transverse and also sagittal images. And we recalled the patient for physical exam and handheld ultrasound. On the handheld, we saw this kind of partially cystic and solid region, which on biopsy turned out to be complicated cysts. This is another patient, 36-year-old, comes in for a screening mammogram. She does have heterogeneously dense breasts. We were able to see on the AP view here a subtle area of hypoechogenicity near the nipple, and you can see the ducts that come in at the nipple here. So this patient was also recalled because we wanted to make sure, were we looking at ductectasia? Was it the area close to the nipple? What were we looking at? So we brought the patient back for a handheld ultrasound, and we did not find an abnormality, and this was just shadowing and hypergogenicity, possibly secondary to the area near the nipple and Cooper's ligaments. We were also able to confirm known findings in our patients that we've been following for years. This is a 52-year-old that comes in for a screening mammogram. She does have dense breasts bilaterally. We've documented in the past on handheld ultrasound that she has a prior complicated cyst. We're able to also find this on automated breast ultrasound and correlate. This is a 71-year-old that came in for a screening mammogram. She has a known mass in the inner part of the breast that's been biopsied in the past. On handheld ultrasound, you see this kind of hypoechoic ovoid structure. And here we see it in automated breast ultrasound. And you can see it on the coronal view and also on your trans and sagittal views. For us at our center, our recall patients, these are patients that are screening that require additional imaging to clarify a suspicious area, we felt would really benefit from automated breast ultrasound. Typically in our facility, the radiologist will perform the handheld ultrasound. This way, if a patient comes back for additional workup with mammographic images, a technologist may be able to scan the patient using the automated breast ultrasound unit, and if the exam is normal, that may eliminate the radiologist having to spend additional time and do additional handheld ultrasound. Of course, if there's a suspicious finding on the full breast ultrasound, then that patient will go on to handheld by the radiologist. The diagnostic workflow in our clinic was such as like this. If the patient has a screening mammogram and a normal exam, they go home. If there's an abnormal mammogram and they're here, we'll recall them and do additional views. If that's benign, they may go home. If the suspicious area doesn't go away, the radiologist may order automated breast ultrasound, and that's a benign, the patient goes home. The suspicious area doesn't go away, or there's a question on the automated device, then the patient goes to handheld ultrasound and a breast exam. That may be okay, and then the patient goes home, or the finding persists and we go to core biopsy and possibly MRI if we need to. If over here the mammogram is abnormal and highly suspicious, the patient may go straight to handheld ultrasound and physical exam and onto core biopsy and MRI. So we have found a way to utilize the automated breast ultrasound in our workflow. This patient here, you can see that we're able to annotate right on the coronal view. You can see the nipple marker. We're able to annotate an area in question right on the workstation while we're reading. So we can annotate. This is the patient that we called back because we didn't know if this was a real finding or ductectasia. The workstation will tell you what breast you're in. You're able to measure. It tells you how far you are from the nipple. So the workstation is very helpful as you're reading. So this is a small hypoechoic area that you can see on the coronal and also on the subsequent trans and longitudinal images. You can also see it on the medial view and the lateral view. So when you do find it on every single projection, definitely that documents that this needs to come back. Most of the time, this may be inspissated material in ducts or fibrocystic changes, but you do need to bring the patient back and do a needle biopsy and make sure that this is nothing to worry about. I do have some images. This is courtesy of Sweden and the Font Central Hospital. This is a 50-year-old woman, comes in for a screening exam. She was called back for additional exam because she had several calcifications in the upper portion of her left breast. Here is a magnification view of the upper portion of her left breast. She does have dense breast tissue and diffuse calcifications all through the entire upper outer quadrant. The craniocaudal view also shows diffuse calcifications throughout. The right breast reveals dense constitutions that are remarkable. The patient had three-dimensional automated breast ultrasound, and you can see here, this is a cross-section of the subareolar area. You see distended milk ducts here containing these echogenic material within them that are calcifications. And you can see the confirmation here that these distended ducts are full of calcium deposits and inspissated material, and this is a very suspicious finding. On the multi-slice, you see that this extends throughout these dilated ducts with the echogenic material within them. There are calcium deposits. And here this continues on. It goes from nipple all the way back to chest wall. These are 2 millimeter thick slices, and we're deeper, closer to the chest wall here, and this abnormal finding continues in this patient. And you see that these are hypoechoic regions that are mass-like all through the entire breast. This is an MRI, and this is in courtesy of Dr. Ingverson. And you can see that the enhancement here is diffuse in this breast. There's background enhancement in both breasts because the patient is quite fibrocystic. Here is a sagittal image of this cancer, which is quite large, measuring 10 by 6 centimeters, grade 3 in situ carcinoma, and also 1.8 by 1.2 centimeters invasive ductal cancer. The recent literature, there's been quite a bit of literature out about automated breast ultrasound. This was a paper that was presented at RSNA in 2008 by Dr. Hovhannissian, and what she found was that automated breast ultrasound should not necessarily replace handheld, but rather be used in conjunction. They found that the automated breast ultrasound device did not identify 9% of the lesions seen on handheld, 2 of which were high risk. They concluded that full field breast ultrasound is time efficient for the radiologist, and because it's very difficult with handheld to scan the entire breast. And it's also time efficient for the radiologists themselves. They don't have to be there scanning. They can read these images later. However, they felt that it should not replace handheld because it doesn't identify every lesion. Also, implementation into workflow is difficult because currently, although this is changing, a screening ultrasound is not typically performed for women with dense breasts. We did look at some additional literature, such as by Kelly. He actually published this article on breast cancer detection using automated whole breast ultrasound and mammography in radiographically dense breast, European Radiology this year. They found that automated ultrasound resulted in significant cancer detection improvement compared with mammography alone. The additional detection and the smaller size of the invasive cancers may justify the technology's expense for women with dense breasts and are high risk for breast cancer. So these authors clearly understand that it's helpful. It may find additional small cancers that will not be perceived for years, possibly, until they're larger and more serious. But they do realize the expense to healthcare that this device may cause, as screening ultrasound currently is not covered by most insurance companies, and that may be a cost that the patient may have to take on. So the future of full field breast ultrasound. Currently, we don't have computer-aided detection. That would really help speed interpretation because there are several hundred images to sort through. And workflow continues to be problematic as we're not necessarily able to read the images on our third-party workstations. So while we're reading our mammograms, our handheld ultrasound, our MRIs, we should be able to read our automated breast ultrasound images too, but we have to read that on the proprietary workstation for the unit. And the third thing is there is a learning curve in order to learn how to interpret the automated breast ultrasound images. While it takes a long time early on, you do get better at identifying lesions, at identifying Cooper's ligaments or duct ectasia, but there's definitely a learning curve, like with any other modality. And that brings us to the end of our talk. Thank you very much.